Welcome to Drug School, and today we're going to be talking about the clinical implications of legalizing marijuana. So, welcome and enjoy the show. Welcome back to Drug School. My name is Adam. I'm your instructor for this course. And I want to preface this episode that I practice in Michigan. So, recreational marijuana became legal in December of 2018. Other states, it's been in practice a lot longer than that. And when I thought about the implications of marijuana becoming legal, I realized that unlike alcohol and tobacco, which our pharmacy systems can help us screen for in the clinical setting, um, marijuana does not have that same flag in pharmacy systems. It just doesn't exist. And there's a lot of stigma around that, and we'll get into that stigma in our case study a little bit later in this episode. But uh, unlike alcohol and tobacco, where we can screen for these interactions in our pharmacy setting, we don't have that same mechanism for marijuana when it becomes popularized in use. And that clinical implication is going to be drastic because with most alcohol based drug interactions, they're either going to be uh, drugs where we don't recommend that you use alcohol, or drugs where alcohol is absolutely positively not an option, such as metronidazole. And in tobacco, we all know about the estrogens um, not cooperating with smoking, causing blood clots. THC has so many drug interactions. Tetrahydrocannabinol has absolutely a ton of interactions, and we're going to get into those in this lesson. For the general public who's watching this for their own pure entertainment, I don't know how you'd call this entertainment, but we'll go with that. Um, I have to first off preface this. The Board of Pharmacy is going to tell me I have to do this. I do not hold a license to provide medical advice. I am a pharmacy technician. I do not have a license to consult patients. So do not take anything in here as a substitute for the medical advice of a physician or a pharmacist. Questions related to your particular condition should be addressed to your doctor or pharmacist. This program is intended to educate pharmacists and pharmacy technicians on the safe use of medications uh, in the presence of legalized THC. So, with those disclaimers out of the way, um, don't send me a lawsuit. Don't send me an administrative complaint. This is not medical advice. It's simply just an educational tool. So, with that in mind, today I'm going to talk about the pharmacodynamics of THC. We'll talk about the side effects of THC, how to recognize them, and you may be called upon to realize that you have to treat those side effects over the counter because somebody may come in having those ill effects, and you may need something on the opposite side over the counter to counteract those interactions. And then we'll talk about the drug interactions with THC, and then how to approach that conversation. And we'll do that through a case study I created in a little animation. It'll be a lot of fun. My resources for this, I consulted Clinical Pharmacokinetics 2003 by Groton Herman. I also consulted the dronabinol package insert and the brand new Epidiolex package insert because And the reason I picked these two is dronabinol is essentially a synthetic version of tetrahydrocannabinol, and Epidiolex is one of its chemical derivatives. It's in the cannabinoid class. And since the most popular version of doing this drug, THC, is through the inhalation method, both um, the chemical components of Epidiolex and the components of dronabinol are going to be found together. And I retrieved those package inserts off of the Daily Med website. And if you've never been to the Daily Med website, it is a wealth of information. So let's talk about the metabolism of marijuana. It predominantly is metabolized by your liver, and there are 100 metabolites that are generated when this drug is metabolized. And we'll talk specifically about two of them. But before we get there, there are a couple of other places where this drug can be metabolized. The lungs is one of them. That's a minor metabolizer. Although when you inhale the drug, the lungs do some metabolism of THC. And the heart, which is also another minor metabolizer of THC. And the heart has some of the chemical side effects of the drug that are going to be present. As far as the metabolites go, there are two that we specifically talk about. 11-hydroxy delta 9 tetrahydrocannabinol, and that is a mouthful. I realize most people don't get into the chemical names of the drugs. When it comes to the metabolites, these are very important. That is the psychoactive response. It is the only metabolite that crosses the blood-brain barrier. The other metabolite that happens in the body is 10-nor-9-carboxy-tetrahydrocannabinol. That is the active metabolite. A couple of other things about this drug that you'll realize is that this drug is lipophilic, which means it permeates tissues very easily and it allows for very rapid absorption of the drug. And we'll see this when we talk about times to onset in just a moment. As far as drug tests go, if you are in the position where you have to do this type of testing, you can expect that, and the metabolites, the 11-hydroxy metabolite and the 10-nor-9-carboxy metabolite will be present in the blood for about 8 to 12 hours. And you'll be able to measure that. After about 12 hours, it's undetectable in the blood. Doesn't mean it's not there, just means it's undetectable. Total excretion of the drug takes 24 to 48 hours, according to the clinical pharmacokinetic textbook that I was reading. Onset and duration of action. The most common way you're going to see this is inhalation. You won't commonly see THC injected, and the reason you won't see THC injected is that the side effects are intensely rapid, and the side effects are usually very undesirable. Paranoia, anxiety, jitteriness, heart palpitations. Those side effects will manifest themselves very rapidly in an injection situation. Inhalation, even though it has the same onset of action time, the side effect profile is not as prolific when it comes to being metabolized, because it still has a few channels it has to go through before it gets into the bloodstream, such as the lungs. It has to get through the alveoli, it has to get through the heart, it has to get pumped out into the liver and then metabolized. You're skipping a few steps if you inject the drug directly. But the onset of action for THC is generally seconds up to 10 minutes for an injection or an inhalation, and the duration of action is relatively short. It's about 3 to 6 hours, depending on how well the person metabolizes the drug. Now, if they take the oral capsule, or they take an edible, for example, the oral capsule and the edibles take about 30 to 90 minutes to kick in, and they have a longer duration of action. It's 8 to 12 hours. The reason for this longer duration of action is because the drug actually has the potential to permeate any intestinal tissue it finds. So after it goes through its initial digestion and as it goes through the intestines and into the colon, the drug can release anywhere within that particular uh, area of the body. So you can have effects and duration of the effects of this drug for a long period of time as the drug transits via being digested through the edible. So duration of action for an oral edible on marijuana is generally a lot longer. Ophthalmic, I wouldn't recommend going this route because you generally have to suspend it in something that is oil based, which is mineral oil. They did do testing on it. It takes about an hour for it to kick in. And the people that were in the study, there were 6 people, and we got very descriptive results on its duration of action. It basically said just several hours was the duration of action. Several hours is a little bit vague for my book, but I would guess probably somewhere in that 3 to 8 hour range would most likely be warranted. But we don't know because it wasn't quantified in any of the literature. Rectal is base dependent. If you use a fat-based base to make the suppository, it'll absorb a lot faster, but generally speaking, we're talking about 30 minutes. Again, duration of action is 8 to 12 hours because as that suppository slowly dissolves, unless it's excreted really quickly, meaning the suppository doesn't have a lot of contact time, that'll be on the shorter end. If it's given the full contact time, it will be closer to that 12 hours. As far as transdermal goes, onset of action and duration of action were not given. And that is because it is base dependent and there are a wide variety of bases that can be used. And the study was done on a very small number of people. So as far as a transdermal preparation of THC, we really don't have a good answer on that one. And mucosal administration is going to be relatively fast. I probably would quantify that relatively fast to be similar to that of an injection or an inhalation. So if you're using a nasal spray, mineral oil nasal spray, or if you're using a sublingual formulation that is oil based, I would imagine you would get a response similar to that of actual inhalation. So these were the bioavailability studies that we could find. Again, this is out of that clinical pharmacokinetics book. This was their chart directly. As you can see, inhalation has the best bioavailability response, and it was, generally speaking, a marijuana cigarette that people used. Generally speaking, you're looking at about a bioavailability of, roughly speaking, 35% if you go inhalation. If you go oral, you're probably going to get about 15%. And the 2 patients that used THC hemisuccinate in a suppository form got bioavailability that was 190 to 220% of bioavailability. And that probably equates out to about a 20 to 25% bioavailability of the drug in that particular instance. So it does have medicinal uses. The medicinal uses that have been noted, we know it's an antiemetic. Dronabinol is marketed specifically as an antiemetic drug for HIV patients and for oncology patients. We know it is an antispasmodic because Epidiolex was approved specifically for the reason of being an antispasmodic drug, and the 9-carboxy metabolite is responsible for that antispasmodic reaction. We know it is an appetite stimulant because we've known for years since the 70s that smoking marijuana gives people the munchies, and that's been a known side effect of the drug for a long period of time. It does have analgesic and anti-anxiety properties, and in Michigan, in the medical marijuana law, it specifically states that you can use it for those 2 properties. And the ongoing debate is whether using medicinal marijuana would be a great substitute to the opioid epidemic. I think you're trading one epidemic for another in that particular instance as people try to look for pain relief for the everyday minor aches and pains of life. And I think what you're going to end up seeing, and this is my personal opinion, is that people will trade opioids for THC. So the jury's out on this one. I don't think there's enough data to support whether or not it is the solution. You'd have to look at places where it's already been recreational legalized for a long period of time to determine whether or not it reduces opioids. And the only pure example you could provide of that would be either Portugal or the Netherlands. Um, and I just don't think the data is there to say that it's going to switch from one to the other because they don't use opioids in Europe the same way that we do here in the United States. So only time will tell. I think it merits further study. But as far as being able to prove whether or not it's going to be a substitute for opioids, I don't buy it. Most medicinal uses are from the CBT2 receptor agonist metabolites of the drug. And CBD1 receptor agonists are responsible for the psychoactive therapy. So if the anti-anxiety, the analgesic, and the appetite stimulation are all going to be CBD1 receptor agonists. That 11-hydroxy metabolite is going to be the CBD1 receptor agonist. CBD2 is usually the 9-carboxy uh, metabolite talking, or cannabidiol is going to be the other version of that you'll see. Side effects typically range, and this list looks probably fairly paradoxical. Sedation, euphoria, paranoia, altered time perceptions, so people will perceive time differently. Usually they view time as moving either slower or faster than it really is. Decreased body temperature, an unsteady gait, and what you're seeing here, a lot of these items are also what alcohol induced intoxication looks like. The sedation, the euphoria, the altered time perception, decreased body temperature, unsteady gait, fragmented thinking, and these are all also going to represent a reduced response time to stimuli. So this is why driving drunk is illegal, and this is also why driving under the influence of a controlled substance is illegal, because those changes in your response times are going to be problematic. Dry mouth, gastroparesis is a possibility. You'll typically see red eyes, and this is why the ophthalmic preparation is not preferred. And the reason why is what will end up happening is you will actually open up the blood vessels in the eye, and that's what causes those people to look bloodshot in their eyes, is those blood vessels have been opened up. You get reduced eye pressure. You can create orthostatic hypotension. So patients who are already on antihypertensive drugs could actually become hypotensive if they're well controlled. If people normally have a well controlled blood pressure, they may develop hypotension. They can also develop a tachycardic situation, and patients who are already at risk of going into tachycardia are at a higher risk of going into tachycardia by using THC, and that's in the reference to the literature. As far as the drug interactions go, I had to put it in two columns because the list was getting way too long. So we know CNS depressing agents increase CNS depression. It's an additive effect across all of them. So any drug that depresses CNS, alcohol, the opioids, barbiturates, diphenhydramine, the benzodiazepine class of drugs, all of those are going to be CNS depressing drugs. If you use marijuana on top of those those CNS depressing drugs, you will increase CNS depression. The sympathomimetic drugs increase the risk of tachycardia. Um, so amphetamines, ephedrine, pseudoephedrine, albuterol, and I specifically listed albuterol in here because one of the ways you get around tachycardia in the use of marijuana, the antidote for that is metoprolol, which is a beta blocker. And what you end up possibly getting is a situation where you're going to have an asthmatic, and asthmatics are contraindicated in beta blockers. So if you have an asthmatic who presents with THC intoxication and has also been hitting up their albuterol inhaler, if they become tachycardic as a result of the combination of the two drugs, you can actually reverse the situation and then trigger an asthma attack at the same time. And that could be potentially a dangerous situation. So with the sympathomimetic drugs, you really have to be careful with marijuana use, especially since THC use usually has other controlled substances used along with it. The anticholinergics also have additive tachycardia listed as a side effect. That would be pretty much the entire antihistamine class and scopolamine. Diphenhydramine was specifically listed. I would imagine you could probably substitute diphenhydramine for any of the first generation antihistamines, so doxylamine, chlorpheniramine. The literature was sketchier when you got to the second generation of the antihistamines, and that was loratadine, cetirizine, deloratadine, and the like. Those were a little bit sketchier when it came to whether or not they caused an anticholinergic effect. Tricyclic antidepressants have additive tachycardia as well. This is a paradoxical effect, as well as hypertension. The previous slide, when I was talking about side effects, I talked specifically about having hypotension with THC. And in this particular instance, if you mix it with a tricyclic antidepressant, amitriptyline, nortriptyline, diazepamine would be examples of these. You can actually get paradoxical effects out of the THC, and one of the paradoxical effects you get is actually hypertension. Antipyrine, barbiturates, ketamine, and propofol. And if you work in inpatient hospital pharmacy and you get into anesthesia, it should be worth noting that patients who are regular marijuana users coming in for surgery do have decreased clearance for all of the anesthesia induction agents, which means you're going to have to use a lower dose of the anesthesia induction agent in patients who test positive for THC. So this may actually change in hospital pharmacy. This may actually change some of the protocols for anesthesia that we use, because you're going to get enhanced sedation out of patients who do regularly use THC. Disulfiram and fluoxetine cause hypomania when mixed with THC. The effects were not very well documented in the literature that I could find. Theophylline has a very interesting drug interaction in that it's blocked. Its absorption is blocked essentially by THC being present because they go through the same CYP pathway. The NSAID drugs do reduce the anti-inflammatory effects of THC, and they also reduce the euphoric effects of THC. So contraindication for an NSAID drug is not really there, but it is possible. So keep that in mind. So with that, I wanted to take this time to have you meet Bob and Claire. And Bob and Claire are a fun pair. All right, so let's take a look at a case example. This is Bob. He's your average pharmacist. He's done this job for decades. With Bob today will be Carla. Carla is going to be a mid-20s female. She uses recreational marijuana a day or two, and she's on no other regular medication. So Carla comes into Bob's pharmacy, and today she is going to be suffering from a head cold. She's congested, she's been running a fever, has a non-productive cough. Bob introduces himself to Carla, Hi, I'm Bob the pharmacist. What brings you in today? Carla's going to tell Bob all about the head cold she has. So, well, I caught a cold, I'm congested, coughing, and I have these headaches. Bob is going to be thinking about that as he goes through his clinical consideration. Sounds like the flu, but we'll treat it the same way, OTC anyway. So he starts to ask Carla a few questions. And the big thing he wants to know about is, do you take any medications I need to be aware of? And I really don't like this I need to be aware of phrase that we throw into our clinical phrasing every day. So we really need to get rid of that. So we're going to change Bob's phrasing of this question. And we really have to change Bob's phrasing of this question because certain things clinically now have changed. And that's going to change the way Bob brings this question to his patient. So Bob, being the astute pharmacist that he is, has been learning all along about what to change. And he goes, well, do you use anything daily like ibuprofen, alcohol, or do you smoke anything? Carla's going to get a little pensive about this because she's still aware of the stigma around marijuana. She should ask, thinks, should I tell him about my marijuana use? She might get a little bit defensive and ask why Bob needs to know this. I didn't expect an entire medical history. So Bob's going to tell her a great rationale. And he's going to say, well, you'd be surprised how many things that we do on a daily basis interact with medications I give you. And Carla's going to tell Bob that that makes sense. Well, that makes sense. Then you need to know about the marijuana I use a time or two a day. Just don't tell my boss. Bob, being the funny guy that he is going to say, well, thank you for telling me your secret's safe with me. Now let's take care of your symptoms. So, what are we going to recommend to Carla? So now that we've met Bob and Claire, um, where does this leave the retail pharmacist when it comes to making an OTC recommendation on an NSAID drug? For the flu, for example, or antihistamine drugs, or pseudoephedrine. Well, when we treat flu symptoms or we treat cold symptoms, we usually give a whole pile full of drugs to treat those symptoms. So, Mucinex D is a common go-to. I've worked under dozens of pharmacists in my career, and I could probably quote all of them going to the same places on the shelf. Usually, the Dayquil/NyQuil combination comes up as a a potential solution to flu-like symptoms. Sometimes it'll be ibuprofen mixed with Mucinex D. It might be just some plain pseudoephedrine, Mucinex DM. Mucinex DM presents an interesting challenge because dextromethorphan and ketamine are chemically related to each other. So there is potential possibility you might have some interaction risk there as well. Uh, so when we talk about these drugs, we don't want to leave marijuana out of the conversation when we are talking to patients that are present in the regular everyday pharmacy. Now, you can directly ask patients. So when we were talking about Claire's marijuana use, hers is very, very light compared to most. So you most likely can't smell it on her. And with a lot of them going to vaping nowadays, you're not likely to get the same smells you used to. I remember my parents um, back in the 80s would tell us that you could smell a hippie from a mile away, and that was just because you could smell the marijuana smoke on them. And there are several patients throughout my career in pharmacy where I would get that distinct odor off of them and you can smell it. But now that we've gone to vaping, it's not as strong of an odor and you're less likely to actually smell it. Now, it may permeate their skin a little bit like cumin does in Indian food. So if you eat a lot of Indian food, you tend to smell like cumin. In THC presence and marijuana's presence, because it's lipophilic and it infiltrates tissues, you're likely to smell it. I wouldn't put a guarantee that you are. So when we're treating the flu, though, specifically, NSAID drugs will reduce the effectiveness of the marijuana. We might want to disclose that at the outset. Antihistamine drugs are potentially dangerous from a tachycardia situation. Pseudoephedrine is also potentially dangerous from a tachycardia situation. So we have to be really careful with these patients in what we use. And you may be tempted to go reach for that bottle of Tylenol. But before you reach for the presence of acetaminophen, cannabidiol has an interaction for acetaminophen, and it increases the hepatotoxicity of acetaminophen by up to threefold in 25% of the patients. This is out of the Epidiolex package insert. So both acetaminophen and all NSAIDs could potentially be off your option list as far as treating the fever of the flu. So you could recommend using lower dose NSAIDs. You could just disclose that the NSAIDs are going to cause less of an effect on the marijuana if you can detect any use out of that, if you get any clinical information that that's a potential situation. Acetaminophen, I would probably contraindicate in the presence of a THC patient. And yeah, I know I'm a pharmacy technician telling a bunch of pharmacists that I'm telling you not to use a drug, and I don't have the same um, uh, pharmacology training that you do, but acetaminophen already has that hepatotoxic property to it, and if we are going to have cannabidiol present in any of the situation, we really probably want to take a look at avoiding cannabidiol, especially since it was a significant notation in the drug studies that were done on Epidiolex specifically. So with hepatotoxicity being a very strong possibility, I probably would strongly recommend avoiding use of acetaminophen in patients who are also using marijuana. The NSAIDs, the risk isn't very great. It just decreases the effect of the marijuana. So we may just be able to get away with telling patients that you can use this ibuprofen, but just keep in mind it may make your other recreational activities not work the same way they did in the past. So I'm going to leave this a little open because I'm not licensed to dispense medical advice, but I would be interested to hear about how you would solve the challenge of treating the flu with treating the symptoms of flu. So feel free to comment below if you don't feel comfortable doing that. My email address is listed right there. Don't spam me, please. I really don't appreciate that. But that brings us to a close on another episode of Drug School. As always, if you like the series, please like and subscribe the channel. That'll help me out greatly. Also, there's links to Patreon down below. Please make a donation to help make Drug School free to everybody. Thank you for joining us.